Management and prevention of infection of myeloma is a big issue because infections are the second leading cause of mortality in myeloma. And there's a big study from Scandinavia which showed the increased risk of infections in patients with multiple myeloma. The risk for bacterial infections is 7-fold higher, the risk for viral infections 10-fold higher, and the risk is even higher in patients shortly after start of therapy. And we did a study where we asked patients about the infectious episodes before their diagnosis of multiple myeloma was established in the year before. And surprisingly, 56% of patients actually mentioned and experienced at least one infectious period before their diagnosis, in the year before the diagnosis of multiple myeloma has been established. So this indicates the immunosuppressive effect of the disease itself. But then it's complicated by the aging individual, immunosenescence, treatment effects, and morbidities, comorbidities. So there is many causes which contribute to infections. So we have to take utmost care to prevent infections at the beginning, if possible. So what can we do? First of all, there are 4 musts for vaccination, which every myeloma patient should have. And that is very simple and clear. It is influenza, it is vaccination against pneumococci, vaccination against herpes zoster, because there's an excellent new vaccine available, and of course vaccination against COVID-19. And presently 3 doses are considered as basis for establishing a good immune system, and now we recommend a 4th dose, and preferentially with one of the new vaccines which are developed by Pfizer and by Moderna, which also seem to protect against the Omicron BA.4 and BA.5 variant, which is very important. In addition, you have a series of other prophylactic measures, antibiotic treatment, antibiotic prophylaxis, but this is not a treatment for everybody, it's for high-risk groups. And then, of course, you need medical prophylaxis against herpes viruses, acyclovir, in patients who are undergoing treatment with proteasome inhibitors, CD38 antibodies, CAR T cells, that's for sure. And in CAR T cell patients, you should also think about prophylaxis against fungal infections and pneumocystis. Also, these infections are relatively rare. Incidence varies between 1% to 6% in CAR T cell patients, but I think it's an important prophylactic measure which has to be considered. What else? Yes, immunoglobulin can be given, but again, only in specific conditions. If the patients have low immunoglobulin levels and high risk for bacterial infections, or in what we are doing, patients must have repeated bacterial infections in our institution, not responding well to antibiotics, and then we give them a try with IV immunoglobulins, 400 milligrams per kg, and every 3 to 4 weeks. So yeah, what else? What's new on the horizon? Of course, we have drugs which we can use in patients, in myeloma patients with high risk of developing severe COVID disease, who had contact with patients or with individuals who were COVID positive. Paxlovid is probably the way to go, but there is also a new monoclonal antibody which will be approved by the FDA soon here and in Europe, which is more efficacious than Evusheld, and works also against the Omicron variant.